Hey, it's Dr. Rucker. I am going to make a video today for a lot of patients who have advanced prostate cancer or also some concerns about testosterone prostate cancer. I'm going to read from Dr. Friedman's book. The title of this forum post is "The Man Who Claims Prostate Cancer is Caused by Estradiol." In a summary here, combining Dr. Friedman and Leibowitz's work, you could have a protocol to control prostate cancer, combining variations of Lupron, Casodex, Avodart, Arimidex, and then high dose testosterone, where you want the level in the bloodstream to be 1500 to 2000 with Avodart and Arimidex. And then they keep cycling it. I'm not sure if I agree with that, but I'm going to read from this book chapter as an intro. This is crucial because you don't find many people that have knowledge of this, and especially urologists and oncologists. Anyone that knows me realizes I'm quite far out of the box. So I'm just going to create this as an introduction to a different way of thinking. So I'm reading from chapter 12, page 217, improving on Dr. Leibowitz's protocol. Although Dr. Leibowitz's work is having wonderful effects, he is first and foremost a clinical physician, and he does not consider the effects of hormone receptors. However, we can use our knowledge of these receptors to improve upon his good work, theoretically making it even more effective. Dr. Alfred Gilman made an important discovery when he found out how cell membrane receptors communicate messages to the interior of cells. He received the Nobel Prize in Physiology in 1994 for his work on cell membrane receptors. End of quote. So that's from the book excerpt. What's interesting is Goodman and Gilman, that's our pharmacology text at the University of Virginia where I went to college and medical school. Interesting aside. So I'm going to go on to the next important tidbit of information. Also from page 217, quote, recent research indicates that testosterone causes programmed suicide of prostate cancer cells by attaching to the membrane androgen receptors, end of quote. Now on to page 218, Dr. Friedman points out the first question asked, quote, is whether or not his initial androgen deprivation step is necessary, end of quote. So the androgen deprivation seems to be a necessary start to this type of treatment, which is a little bit of misery for men. But apparently that does cause an initial killing of cells. So as I fine-tune a protocol, that makes a lot of sense. So someone presents to you with an elevated PSA of 20, 30, 60, 100, 150. That patient, it makes sense. You put them on Lupron, the PSA drops, then near the third month, you would start them on testosterone cycle with Avodart and Arimidex. So this is all making a lot of sense to me to create a cogent protocol for patients. And I do have a couple of patients on such a protocol as we speak. On page 219, I'm going to go back to quoting the text. Dr. Leibowitz cites the case history of a single patient who didn't use androgen deprivation and was treated with teenage levels of testosterone and low levels of DHT by using finasteride, with a resulting PSA doubling time of 15 years. End of quote. So that PSA doubling time part is important. It took 15 years to double the PSA time on this therapy. That's quite excellent. The next thing he does is look at the logic of using finasteride following androgen deprivation. The finasteride reduces the level of DHT, creating an imbalance that increases the ratio of membrane androgen receptor activity to intracellular androgen receptor activity. In theory, this will increase the amount of killers produced by membrane androgen receptor. By killers, I mean pro-death proteins. In other words, when there are a greater number of membrane androgen receptors, then the cell will produce more self-destruct proteins, leading to the likelihood that cancer cells will kill themselves. Pretty neat trick if you can arrange it. And the good news from the research front is that this is now possible. End of quote. He does go on to talk about, in page 221, basically an art form to understanding how to use androgen blockade with aromatase inhibitor like anastrozole and finasteride. He does say, in the unlikely event that neither of these protocols work, then you're probably dealing with a mutated androgen receptor, and testosterone and DHT need to be avoided. One more quote I want to read. For patients whose prostate cancer is already widespread, there's no question that initial androgen deprivation is the proper protocol. Dr. Leibowitz cites the case history of a man whose initial PSA was 3,346 and whose doctors told him that he only had a few months to live. 4 years after seeing Dr. Leibowitz, his PSA was below 2, and his testosterone was over 2,000. It's hard to imagine this man would have been alive at all, let alone with such a low PSA if he had seen any other doctor in the world. The last thing that's interesting is Dr. Leibowitz gives patients with distant metastasis a mixture of anti-angiogenic drugs. And this fine-tuned cocktail apparently is on his website. This is where some of the protocols I'm using probably come in real handy, where I would use low-dose naltrexone, medical cannabis, ivermectin, fenbendazole, even certain doses of melatonin. So I'm going to leave this as the conclusion. This is a protocol in development, and it's probably, like a lot of medical treatments, it's a bit of an art form, but I see a lot of advantages using this style of thinking in therapy. And if anybody is watching this or reading any of this information, please reach out to me. I'll be happy to do a consultation and go over any of this information with you directly. Thank you.